Do you recognize this very important instrument used during laparoscopic surgeries? If not, let's know more about this wonderful instrument which has helped in performing many laparoscopic surgeries. Hello and welcome to my channel Medicos. In this video, we are diving into the Veress needle, a critical tool in laparoscopic surgery used for creating a pneumoperitoneum. Creating a pneumoperitoneum the safe way is one of the first steps a surgeon should learn in doing laparoscopic surgeries. As doctor and surgeon, understanding the function and correct usage of Veress needle is essential for safe and effective procedure. Let's explore its design, functionality and best practices for its use. There are mainly 4 techniques in establishing pneumoperitoneum, namely the Veress needle technique, direct trocar insertion technique, optical trocar insertion and open Hassan's technique. The choice as to which technique to choose depend on surgeon's preference, habitus of the patient and anticipated previous post-operative condition like adhesions. Now what is Veress needle? Veress needle is a specialized instrument designed for getting access to the abdominal or thoracic cavity. It was invented by a chest physician to aspirate the pleural effusion. With its unique spring mechanism and blunt tip aimed at preventing the lung tissue injury. How does it work? The Veress needle has an outer sharp cutting needle and inner blunt spring-loaded stylet. During insertion, the stylet retracts, allowing the sharp outer sheet to pierce through the tissue. Once inside the cavity, the blunt stylet springs forward, extending beyond the outer sheet to protect the internal organ from the damage. Now let's see anatomy of this needle. It has a stopcock located at the proximal end. It is where the insufflation tubing connects to inflate the abdominal cavity with carbon dioxide. It has a valve which can be closed and opened. The stylet has the spring-loaded inner portion of the needle that protect the internal organ during insertion. It has a sharp beveled tip. It comes in different lengths like 8 cm, 10 cm, 12 cm or 20 cm. The 12 or 20 cm needle is typically used for obese patients, while 8 cm is ideal for thin-built patients who have scaphoid abdomen. It has a diameter of 2 mm. Now let's see about the insertion technique. Always check the patency and the spring action. A small incision is made superior or inferior to the umbilicus, just enough for the Veress needle to pass through. The patient is then placed in Trendelenburg position and the abdominal wall is lifted at the side of the umbilicus to create negative pressure. Hold the needle like a dart, using the ring finger as the guard to prevent the excessive entry. The needle is then inserted at 45-degree angle with the tip towards the pelvis to prevent injuries to bowel and vessels. A groove will be felt once it enters the peritoneal cavity. Avoid moving side to side movement, because if by chance there is any perforation, it may enlarge the size of that perforation. Listen for 2 clicks. Once the needle passes through the linea alba, and the second one when it penetrates the peritoneum. Once we are inside the peritoneal cavity, then confirmation is done. Ensuring that the needle is correctly positioned in the peritoneal cavity is crucial. Here is how to confirm. First is the movement test. The needle should move freely from side to side and anterior posterior. It means we are safely in the peritoneal cavity. Second is the aspiration test. Using 10 ml syringe, aspirate the needle and no fluid should come out if it is in the peritoneal cavity. Then saline test is done. Inject 10 ml of saline and attempt to aspirate it back. If the needle is in the peritoneal cavity, the saline should flow freely without any aspiration. It can also be checked by sudden escape of air from the abdominal cavity and by the hanging drop test. One drop will be hanging at the top of the Veress needle. For drop test, place a drop of saline at the needle adapter. If the needle is inside the peritoneal cavity, the drop will be sucked in. Another method is monitoring the intra-abdominal pressure. Once connected to insufflator, the intra-abdominal pressure should be between 0 and 6 mm of mercury. High pressure indicates either a blockage or incorrect needle placement. Low flow insufflation of CO2 is then started until the intra-abdominal pressure reaches 13 to 15 mm of Hg. The needle is then replaced with sharp trocar and the scope is used immediately to verify the correct entry. The other trocars are inserted under direct vision. If midline adhesions are anticipated, another location is to insert the Veress needle is at the Palmas point. Now let's discuss about the Palmas point. Palmas point is located 2 to 3 cm below the left subcostal margin in the mid-clavicular line. It has been recommended for laparoscopic entry since 1940 due to low risk of visceral or parietal adhesion in this area. The technique introduced by Palmer involves a small incision allowing the insertion of Veress needle through the left subcostal margin. The rigid structure of the thoracic wall provides added stability, offering more controlled insertion compared to the periumbilical area. Palmer's technique is especially useful when umbilical entry is contraindicated. It is also recommended for obese and very thin patients. It is preferred to use left upper quadrant for Veress needle insertion. However, prior to the procedure, it is crucial to confirm absence of hepatosplenomegaly as it could increase the risk of complication. Once the Veress needle is inserted through the Palmer's point, the umbilical site should be inspected for any adhesion or any other abnormality. If these issues are absent, then umbilical port can be introduced under direct vision. When using Palmer's point for Veress needle or trocar insertion, the tip should be aimed towards the stomach to avoid injury to splenic flexure of colon. Additionally, it is crucial to ensure that a nasogastric tube is in place to deflate the stomach, minimizing the risk of inadvertent injury during insertion. Drawbacks of closed technique is that while closed technique is efficient, it has some risk. The blind insertion of Veress needle and the first trocar can lead to injuries such as bowel, bladder, or vascular damage. This is why proper training and careful techniques are paramount. Thank you for watching. If you found this video helpful, please like, comment and subscribe for more content on surgical techniques and tools. Stay safe and keep practicing with precision. See you in the next video. Thank you very much.